Welcome to Around the Couch. I'm Jeff Callos from Kidney Couch. In this episode, I talk about when kidney cancer returns after it has been treated. As with many types of cancer, a return of kidney cancer is commonly referred to as a recurrence. Kidney cancer recurrence is probably the most thought about, talked about, and feared among patients who have been treated for kidney cancer. By treated, I mean by having a mass surgically removed, a partial or complete removal of a kidney that contains a cancerous mass, or having immunotherapy after a nephrectomy. When I think back on my almost 3-year experience in dealing with renal cell carcinoma, it hasn't been the surgical removal of an entire kidney that I've thought about the most. It's whether or not the cancer will return. I think that's true for most patients in my experience. In my case, I had a stage 3, grade 3 tumor removed. Higher stage and grade tumors have a higher risk of recurrence, even when the surgeon feels they removed all the cancerous mass, when they remove part or all of the kidney. Microscopic cancer cells can go undetected by imaging, such as when you have a CT scan, MRI, or a PET scan, for some time. That's why patients who have had a partial or complete nephrectomy to remove a cancerous mass need to have periodic imaging to monitor whether the cancer has returned or if it is spread to somewhere else in the body, like in the lungs, bones, liver, or brain. When imaging is done after a nephrectomy, one of the sites the radiologist looks at closely is called the operative bed, the area where the tumor was cut out or the entire kidney was removed. If cancer returns to the kidney or the immediate area, that's referred to as a recurrence. If cancer spreads to the lungs, bones, or other organs, that's called metastatic kidney cancer. It's still kidney cancer that has spread to another part of your body. For example, it would be called renal cell carcinoma in the lungs. If a person with kidney cancer is later diagnosed with lung cancer, that is a separate, distinct, and different cancer, it's not considered metastatic kidney cancer. It's lung cancer. That's why it's important to have a biopsy of the tumor to determine which type of cancer it is and have the appropriate treatment. Many clinical studies and publications from the medical profession tell us that the greatest risk of recurrence for renal cell carcinoma occurs within the first 5 years after a nephrectomy, with most recurrences occurring within 3 years. Because of this risk, surveillance schedules are set up for patients that include imaging, blood, and urine testing that have been developed by physicians over the years based on the presentation of a patient's cancer type, stage, grade, and any other medical conditions the patient may have. Rather than having a wait-and-see approach of contact us if it hurts, the physician will typically set the patient up on a 3, 6, or 12-month schedule of repeat imaging, a CT scan or an MRI of the abdomen pelvis, a CT scan or X-ray of the chest, and a battery of blood and urine tests. The physician uses established guidelines and their medical expertise and experience with patients to develop a surveillance schedule that makes clinical sense based on how each patient presents. It's important to remember that no two patients are exactly the same. In the end, physicians make a judgment call for your case based on the available science and their experience. Active surveillance is another term commonly used when referring to the monitoring of patients who have been diagnosed with a small tumor in their kidney, usually less than 3 centimeters in size. This is a watch and wait approach of monitoring a mass with periodic imaging to see if the mass continues to grow or changes in any way. A biopsy may be done as well. My understanding is that surveillance and active surveillance are terms that are used interchangeably, but some refer to active surveillance for the monitoring of small tumors only, those under 3 centimeters. Both mean a patient's status is being monitored with periodic imaging and testing to determine if a mass is kidney cancer or whether it has returned. Although kidney cancer recurrence tends to happen most often within the first 3 years after treatment, it has been known to happen many years later. Every occurrence of kidney cancer is unique, and so is every instance of a cancer's recurrence. In my case, because my tumor was stage 3, grade 3, with renal vein invasion, my urologist recommended I have a CT of the abdomen and chest 3 months after my nephrectomy. This was to establish a new baseline for imaging comparison of scans that I would have done in the future. A new baseline for me. Then for the first 3 years, I would have a CT of the abdomen and pelvis and either a CT of the chest or an X-ray of the chest to check for any detectable signs of kidney cancer recurring or spreading. As with all clinical testing, nothing's perfect. Shadows can show up on chest X-rays occasionally. That has happened to me on a couple of times. You think the worst. Imaging is looking for cancer. So a dark spot that could be cancer can really send you over the edge. When shadows do show up, it's common to have a follow-up CT scan or an MRI to take a closer look and rule out cancer. It's unnerving to say the least. If it is kidney cancer, it is metastasized to the lungs and ups your stage to a 4. Surveillance is then more frequent. Treatment is likely necessary. Many times, a shadow is just a shadow, nothing to worry about, like a person's shadow in the night. It's only frightening if you look at it in the wrong way. One of the questions I like to ask a physician is, what would you do if you were me? The question gives the physician the opportunity to answer the question differently, not as your physician, but as a person who is being asked to take a minute and put themselves into your shoes as a patient or one of their family members. I asked my urologist and his chief resident that question when I was debating having a biopsy of the kidney mass before having a radical nephrectomy, and then again when I was debating whether to have a partial or a complete nephrectomy to remove the mass. Now, you might be thinking to yourself whether asking a physician that question in that way is being fair to the physician. Maybe it isn't, but I ask it anyway. You can make the argument that unless you've been diagnosed with cancer, you couldn't possibly know what you would do. Your mind does change. It's no longer hypothetical. On the other hand, if you're asking a urologist who has a lot of experience in the diagnosis and surgical removal of a kidney mass, knowing what they know before, during, and after a patient's surgery, maybe they would have a pretty good idea what they might do. They certainly have a stronger case to be made than most, I think. I also think the question takes the physician off the hook if you will. You're no longer asking the physician for their professional medical opinion. You're asking them to put themselves in your shoes as a patient. You can make the argument that it's not possible for a physician to separate their medical experience and expertise and any recommendations they would have from a personal one, and that you shouldn't put them in the position of having to answer the question in other than a professional capacity. But as I said earlier, I asked the question anyway. In my experience with kidney cancer, when I have asked the question of a physician or a medical provider, there seems to be a longer pause between the answer than when I've asked them for their medical opinion. I think it makes some providers consider the question maybe a little differently and try to put themselves in the same situation. As hard as that is, hopefully you never have to ask that question. Some of the questions that patients like me who have been diagnosed with kidney cancer have on their minds are, how risky is a nephrectomy? Are there any long-term side effects or complications? How much pain will I be in after surgery if I need to have an open surgical procedure versus a robotic one? Will I need any treatment other than surgery? How will my remaining kidney function? Can I live well with one kidney? What are the chances the cancer will return? And how confident are you of that? And the big question, is there really such a thing as being cured? This is the recurrence question in a nutshell. The fear most patients have. It's a question that can only be answered after your death. Did kidney cancer ever return or spread? Cancer can return at any time. No one can tell you with certainty that your cancer will never return. They may be highly confident of that, but they can't be 100% certain. If a physician tells you that, ask them to put it in writing. My guess is that will never happen. Speaking of something that pops up on my radar from time to time, should total body scans or imaging of the abdomen and pelvis be done to screen for kidney cancer in populations where kidney cancer is more prevalent? After all, early detection increases the likelihood of a better outcome and prognosis. What are some of the downsides of scanning your body looking for something sinister? Radiation exposure is one. It's a trade-off that patients with cancer must consider. Do I risk other forms of cancer due to repeat exposure and radiation, as with a CT scan or an X-ray, even if in small doses, in pursuit of identifying kidney cancer as early as possible? The trade-off to me is well worth it. The risk of not having periodic imaging is just too great. Another downside is the unnecessary worry that can be created by seeing shadows within that are nothing to be concerned about. You can chase that rabbit down many holes. More consultations, and testing, only to find you had nothing to be concerned about. In my case, the physician told me the mass in my kidney had been there anywhere from 5 to 15 years. It's not a very specific time frame, and it's telling how little science has been able to pinpoint the growth of cancer in the body, even after decades of having studied cases. That's a range of 10 years. I was diagnosed at age 61. So could the mass have been detected as early as when I was 46 years old? Would it have been too small to be detected that early? The cancer cells too microscopic to be detected at that point? Another is the cost. Health insurance companies aren't really crazy about covering the cost of medical services that are not based on a medical indication to have it done. The worried well, as it's called. That makes sense to a point. The counterpoint to that argument is that detecting medical issues early can reduce the overall costs of healthcare. It's a preventative approach rather than waiting for a bigger shoe to drop. Unfortunately, some hospitals may see this as an opportunity to create a revenue mill for imaging that is expensive and well reimbursed. Another question to be asked is, who should be screened for kidney cancer? Kidney cancer only makes up about 4% of all cancers in the United States. That's about 81,000 new cases each year. Worldwide, it's even less than 4%. So does it make sense to test 100% of the population to detect 4% who have kidney cancer? It doesn't seem cost-effective to do so. Unless, of course, it's you that has cancer growing in your kidney. Before I was diagnosed with kidney cancer, I had none of the typical risk factors for kidney cancer, other than being about 10 pounds heavier than I needed to be. My wife may say about 20. I was on no one's radar. The same holds true for recurrence. Other than the fact that I've had kidney cancer and it was removed, my risk factors are the same as they were before. And finally, do you really want to know what's going on inside your body in great detail? It's kind of like learning how sausage is made. After you do, you kind of wish you hadn't. But getting back on track, some of the symptoms that might indicate there's recurrence of kidney cancer are pain in the lower back or side, fatigue, blood in the urine, weight loss. Or you can feel a lump or mass in the abdominal area that is coming around somewhere close to the kidney. The cancer needs to be a good size to feel it for most people. It also depends on where the tumor is in the kidney. My tumor was well encapsulated within the kidney and in the upper pole. It was about 5 centimeters, that's about 2 inches in size. I never felt a thing. Many times there are no obvious symptoms at all, and that was true for me. As you are no doubt thinking, these symptoms can be related to so many things other than the return of kidney cancer. If only kidney cancer had its own unique symptoms that will let you know that there's trouble within. I have a herniated disc in my lower back, so pain in my back is normal for me. I had blood in my urine for 4 days before I had a CT scan. The blood was coming from a 6-millimeter kidney stone that was stuck at the entrance of the bladder. I didn't lose any weight, and I never felt a lump. Nothing has changed for me now. Imaging is the only chance of detecting and diagnosing a recurrence early. That's why periodic testing is so important, in the first 5 years especially, after being treated for kidney cancer. Whether you're tested with additional imaging after the 5-year mark is a discussion you need to have with your physician and is driven largely based on your individual specific case. The only reason I found out I had kidney cancer in my right kidney was that I was passing a kidney stone on my left. So my primary care physician ordered a CT scan of the abdomen and pelvis. The kidney stone was moving out of the left kidney and traveling south. But there was a 5-centimeter mass in my right kidney that was sitting there just as quiet as could be. I never had any symptoms originating from the right side of my body, ever. As I look back on it, the one symptom I did have was fatigue. I had experienced fatigue for years, but thought it was just stress at work a busy lifestyle, and lack of sleep. Turns out, fatigue was my only indication that I had cancer growing inside me. I was later diagnosed with chronic kidney disease in my remaining kidney after my nephrectomy. And as luck would have it, chronic kidney disease can also cause fatigue. So, on its own, it's not very informative. No one can tell why I got kidney cancer to begin with, and apparently no one knows for sure if it will return for me. That's why closely watching patients who have had kidney cancer for recurrence is so important, especially during the first 5 years after receiving treatment, such as a nephrectomy, when recurrence is most likely to happen, based on multiple clinical studies and publications to date. After having CT scans every 6 months for almost 3 years now, I think it's been time and money well spent to catch any signs or symptoms of kidney cancer as early as possible to improve the chances of treating it. Other than having an IV placed before the CT scan, it hasn't been painful either. I hope this discussion about recurrence and surveillance has been helpful. I'm Jeff Callis from the Kidney Couch. Thank you for sitting in with us. Join us next time around the couch.